All right, welcome back, everybody. So, in this video, we're going to talk about diabetes. We're going to tell you all about it in terms of what is it, what does it do, the complications of it, things you need to watch out for, and so forth. So, with all of that, let's get right into it. So, let's start off. What is diabetes? Okay, you know how we do. We never just want to know level one knowledge, where we know the what, right? We want to know, for instance, level two knowledge is what do the protocols say do about it, and then when we get to level three, we know the how and the why. So, let's jump right into it. So, what is diabetes? Diabetes, first of all, is a disorder of the pancreas. Okay, so we're going to start off. I said it's a disorder. Okay, anybody know the difference between a disorder and let's say, a syndrome? Okay, so we have two different things. One is a syndrome, one is a disorder. What's the difference? A disorder primarily involves one organ. Okay, a syndrome involves more than one organ. Okay. So when we think of the complications of diabetes, that would be a part of a syndrome. But diabetes itself is, it involves primarily an organ. Okay. Now, the official name for diabetes is diabetes mellitus. You'll hear some people pronounce that as diabetes mellitus. I want you to pronounce that as diabetes mellitus. That's most commonly accepted. It's also abbreviated as DM. Okay. Now, I said it's a disorder involving one organ, and that organ is going to be the pancreas. Okay. So that order is going to be the pancreas. So when we look at the pancreas, we have the head of the pancreas, we have the tail of the pancreas, and so forth. Now, I want to zoom in on the pancreas for a moment. In fact, let's just actually make this a little bigger. Okay, let's make that a little bit bigger. Now, what I want to do is I want to zoom in on it for you. Okay. So when we look at the pancreas, in fact, I'm going to label it a little bit better. We have this kind of section in the middle. We would call that, it looks like an island, right? So that island in the middle is what's known as the islets of Langerhans. So let me just highlight that for you for a moment. So this section in the middle is the islets of Langerhans. And then this section on the outside is the other part of the pancreas. Okay. So when we look at the pancreas, it primarily has two functions. So what I'm labeling in blue, so let's change my pointer there. So what I'm labeling in blue is what's known as the exocrine part of the pancreas. So notice that's exo, meaning outside. So it's the part on the outside of the pancreas. The exocrine function deals primarily with enzymes. Okay. So the pancreas has two parts or two jobs. One job, the exocrine job, is to release enzymes. Those enzymes are going to aid in digestion. Okay. So when you eat your food and that food needs to digest, the exocrine part that deals with the enzymes, that's what's going to help you digest your food. The other part that I have labeled in this kind of pinkish color, that part is the endocrine. So we have an endocrine and an exocrine. So the endocrine part, that primarily deals with hormones. Okay. Now, I want to focus primarily on this endocrine part because we're talking about diabetes. So, what hormones are actually released, or what hormones is the pancreas responsible for? So, remember, I told you about this section called the islets of Langerhans, right? Well, that islets of Langerhans, it actually releases three different, or it produces three different cell types. The first cell type is known as what's called alpha cells, okay? The next cell type is known as beta cells. And then the final cell type, that's known as delta cells. So we have three cell types that are released or produced by the islets of Langerhans. Those cell types are let's change, sorry about that. Those cell types are the alpha cells, the beta cells, and the delta cells. So remember, alpha, beta, delta. Now, what do these cells produce? Great question. So the alpha cells, these alpha cells, they produce a hormone called glucagon. Okay. So alpha cells produce glucagon. Now, what is glucagon? Great question. So, glucagon, here, let me free up some space here. So, glucagon is a hormone. And what does it do? Its job is to raise the blood glucose level. Okay. So basically, it raises your blood sugar. When your blood sugar gets too low, glucagon gets released to say, hey, let's get this sugar back up. Now, that's alpha cells. Then we also have this beta cells. So these beta cells, so the beta cells, they produce the hormone insulin. Okay. So, diabetes is a disorder of the pancreas that involves insulin. You've heard of people having to take insulin for diabetes. Uh, and the reason why is the job of insulin is to lower the blood glucose level or lower the blood sugar level. So, when the sugar gets too high, insulin actually brings it back down. And then the final cell that gets produced, these delta cells, they release something called somatostatin. Somatostatin. Okay, say it with me. Somatostatin. So, somatostatin. What is somatostatin? Somatostatin is a hormone that's basically the kill switch for the body. When you need to slow things down, we use somatostatin, or the body naturally releases somatostatin. Now, fun fact, do you know of a drug that actually works just like somatostatin, a drug that we would actually give someone? That drug that mimics somatostatin, or what's called a somatostatin analog, that drug is known as octreotide. Octreotide. Octreotide is a drug that's given, especially in the context of esophageal varices. Somebody is bleeding significantly from their esophagus. We need to cause profound vasoconstriction, stop all that bleeding so they don't just bleed to death. We would give them a drug called octreotide, which is a somatostatin analogs. All right, so let's recap that. So far, we've said that diabetes is a disorder of the pancreas. The difference between a disorder and a syndrome is a disorder primarily affects one organ, whereas a syndrome affects multiple organs. Okay. So it involves the pancreas. We said the pancreas has two functions. How many functions? That's right. It has two functions. Those functions are the endocrine function and the exocrine function. The endocrine function of the pancreas produces or releases hormones. The exocrine function releases enzymes, okay? Those enzymes aid in digestion of your food. And then the endocrine part that releases the hormones, those hormones are made in this special location within the pancreas called the islets of Langerhans. Here, let me just write that out. So this section, let's change that color. Sorry about that. That section is known as the islets of Langerhans. Okay, the islets of Langerhans. And we said the islets of Langerhans produce these three cell types. Those cell types are alpha cells, beta cells, and delta cells. The alpha cells release glucagon that raises your blood sugar. The beta cells produce insulin that lower your blood sugar. And then somatostatin is kind of the kill switch that like stops everything. Okay, so we good so far. Now, we said that diabetes is involved with insulin. So, when it comes to diabetes, here's what I want you to know. So, diabetes, there are two types. So, diabetes, let's do that better because I don't want you talking about my handwriting. I can hear you right now. So let me let me write that better. So diabetes has two types. The first type is type 1. This used to be called juvenile onset diabetes because it primarily affected children or they were born with it. And then there's type 2, which was formerly called adult onset. Now we want to go with terms like type 1, type 2. Type 1 diabetes is what we call insulin dependent. That means they have to take insulin. Like if you depend on your parents to take care of you financially, you need your parents, right? In type 1 diabetes, you need insulin. So in this situation, the body is actually not making insulin. So those type what cells make insulin? Remember those the cells that make insulin are the beta cells. They're the ones that make insulin. So the beta cells of the islets of Langerhans make those. But in type 1 diabetes, your beta cells are not working well, so you're not making the insulin. So basically, what I want you to know is in type 1 diabetes, you're not making the insulin. However, in type 2, you make it, you just don't use it well. So we call that insulin resistance. Make sure you're talking out loud with me. What do we call it? We call it insulin resistance. This is where you make it, but it's not used, let's say, correctly or not used effectively. Okay. So type 1, you're not making it. So that's why we have to give that person insulin. In type 2, you make the insulin, but you're just not using it well. So this person is not usually insulin dependent. They don't normally take insulin, but we'll probably have to give them medications to kind of take the place of insulin or to act similarly to insulin, like metformin. Metformin increases, it activates gluconeogenesis. Okay. Now, here's what I want you to know. So that's so far we've said what diabetes is. We've talked about the different types. Okay. Now, how does diabetes cause all these problems? Remember, I said that there's also a syndrome, and the complications of diabetes kind of produce this syndrome. So, first of all, let's talk about what exactly happens in diabetes. Okay. Here's what I want you to know. So, when your blood sugar gets too high, and first of all, what is too high? Well, let's define that. So, what is a normal? Oh, you don't see me. All right. So, what is a normal blood glucose level? Depending on which book you look at or which lab you're referring to, they'll have different ranges, but it'll be somewhere in this range. It's going to be about 80 to 110. And in the US, we measure diabetes, or I'm sorry, we measure blood sugar in terms of milligrams per deciliter. So a normal blood sugar should be about 80 to 110 milligrams per deciliter. So that's normal. So, but just like you have normal, you also have low and you also have high. Okay, what will we consider low? We're going to say definitely less than 60 milligrams per deciliter. That's low. Now, on your glucometer machine, may say low when it's down to like 30, 25, 20. That's dangerously low, but we're going to say it's definitely low or it's hypoglycemic. Hypoglycemic when the blood sugar drops to below 60 milligrams per deciliter. Okay. And then what will we consider high? Now, your machine may say high when it reaches like 500, 600, something like that. But in terms of what do we consider hyperglycemia? So, hyperglycemia, that's going to be, for purposes of this discussion, we're going to say greater than about 200 milligrams per deciliter. Okay. Now, how is diabetes diagnosed? So, how do we diagnose it? Well, we look at the blood sugar level itself. And so we would do a fasting blood sugar. So, fasting blood sugar. So, you're not going to have anything to eat or drink for about 8 hours. Then you're going to go to the lab. They're going to draw your blood and see what your level is. We want that blood sugar level to be less than 126 milligrams per deciliter when you're fasting. Okay. But because blood sugar levels rise, they fall, they go up and down with different meals, sometimes that's not the best indicator. So, in that case, what we're going to look at is your hemoglobin A1C. And we want your hemoglobin A1C to be less than 6.5. Okay. Now, your hemoglobin A1C, why do we use it? It's because it actually looks at an average of the last 90 days, or so the last 3 months. So it's going to be a lot more accurate in terms of how your blood sugar levels have been. It looks at the last 3 months worth of data and it kind of figures out, okay, if your last 3 months, your hemoglobin A1C has been over 6.5, okay, now we're going to say that you're diabetic. Now, what happens when this blood sugar keeps rising? So your blood sugar goes up, 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 and away. So let me show you what happens. Well, we have small blood vessels, so things like capillaries, and then we have the larger blood vessels, okay? So we'd say like micro and macro blood vessels. On a smaller scale, when you're talking about those capillaries, what happens is all that sugar starts to damage, for instance, these endothelial cells that surround the capillaries, and it causes those capillaries to leak. The word for that, if you remember from the allergic reaction video, the word for that is increased vascular permeability. I know that's a fancy word. What that actually means is it just stuff is leaking out that's not supposed to be leaking out. Okay, so the membrane is more permeable, means that stuff can just get in and out of it. Normally, there's a barrier there, but once it starts leaking, things can just move in both directions. Okay, that's what happens on a small level. Now, when all those small, tiny capillaries start to get damaged, all right, so let's say here's our person, and they've got these little tiny capillaries all over their body. Well, what about, for instance, in their eyes? Okay. If we damage the small blood vessels that supply blood to the eyes, now they can have conditions like diabetic retinopathy. Okay. All right. So let's break that down. Diabetic is pertaining to diabetes. Retina is pertaining to the retina, so in the back of the eye. And then the pathy is pertaining to disease. So we're talking about a diabetes causing a disease or disorder of the eyes. So that's diabetic retinopathy. Okay. Where else do we have these small blood vessels? Well, let's say in the kidneys. Okay. In our kidneys, we can have damage to the vessels that supply blood to the kidneys, and that's going to lead to, for instance, what would you guess that is? Let's see. Okay, so that word is going to be diabetic nephropathy. Diabetic nephropathy. Okay, let's break that down. Nephri means pertaining to the kidneys. What are some other words that have nephri in it? Like nephritis, nephritic, nephrotic, um, nephrology, nephrologist, right? All of those, nephritis, all of those things have nephri in it, meaning pertaining to the kidneys. So, one other complication is diabetic nephropathy. Another complication of diabetes, for instance, let's say we start to affect the peripheral nerves, the nerves going to the, let's say, the fingers and toes. Now, we damage those nerves and the patient no longer feels anything, and they can lead up or end up with a condition called diabetic. What would you guess that is if we're talking about nerves and disorder of the nerves? So it's probably going to have like pathy on it. And then the word for nerve, or the root word for nerve, is neuro. So it's diabetic neuropathy. Okay. Diabetic neuropathy. This is where the patient can't feel anything. So think about that. If they can't feel with their fingers and toes, especially their toes, it's so easy. Imagine this. They're walking in their house, they're walking outside, they step on some broken glass, they step on a nail, anything, and they cut their toe. They cut underneath their foot. Because they didn't feel it, they didn't notice the sensation of pain. What's going to happen? Now they've got an open wound under their foot. That foot can allow all kind of bacteria to go in from the outside to the inside. Eventually, it can cause an infection locally right there in that area. So now before they know it, they've got a whole open wound under their big toe, for instance, and that can lead to a larger infection, and eventually it can turn to gangrene, where the tissue actually starts to die, starts to stink, it literally starts to rot, and it'll often result in an amputation. So when you see people, they lose their big toe, then they lose other toes, then they lose a part of their foot, the whole foot, a below the knee amputation, and above the knee amputation. It's because that disease has continued to progress. That infection has continued to progress. So diabetic neuropathy is a major complication. So we definitely want, for instance, we want patients to be, it's a good idea to maybe use house shoes inside their house. I don't recommend you use your regular shoes inside the house, because we don't want to bring all that nastiness from outside to inside, but definitely have a dedicated pair of shoes, house shoes, that you're going to wear inside. It's actually not a good idea to walk barefoot, especially if you're diabetic. Okay. Now, so those are some of the micro vessel changes that happen. So we said on a micro level, when it comes to these capillaries, we have all this leakage, this increased vascular permeability. It causes things like diabetic retinopathy. It can cause diabetic nephropathy and diabetic neuropathy. Okay. Now, what about on a big level? Let's say bigger blood vessels. Well, let's say if I put, we're going to use blue for sugar. Let's say if I put all this sugar, let's say, hold on, let's put all this sugar inside the blood. Imagine if you're making imagine if you're making some Kool-Aid, right? So here's where I am. We've got this blood vessel, and I'm going to put some sugar molecules inside this blood vessel. Now imagine you're making Kool-Aid, and I put a little bit of sugar inside the container, right? So let's say I've got some sugar with just a little water. And if I keep adding more and more sugar, what's going to happen to the thickness of it? It's going to get thicker, right? Just like if you're making Kool-Aid. Well, the same is true inside your blood vessels. If I keep putting more and more and more sugar inside that blood vessel, the thickness of the blood is going to get thicker, okay? Now, remember from our other lecture, we said that there's this thing called Pasteur's law, where it's blood flow is determined by okay, this is the formula for blood flow. Okay, and we said that thickness, marked by this letter N here, thickness, so the thicker something gets, the less blood flow we have, just straight from the equation. Okay, so let's put some more and more sugar inside this. So now we're just going to keep getting thicker and thicker. Here's where the problem comes from. All this extra glucose actually turns to something called sorbitol. What does it turn to? Sorbitol. All that extra glucose in the bloodstream turns to sorbitol. And that sorbitol actually pulls in a lot of other proteins, it pulls in a lot of other chemicals, causes a whole series of reactions to occur, and it ultimately damages the blood vessel. So what will end up happening is this blood vessel can now, for instance, it can vasodilate. We can also have clots that form, okay? And go back to the allergic reaction video where I actually explained the prostaglandin synthesis pathway about the clots. And I'll do a separate video on the clotting cascade where I'll talk about the intrinsic, the extrinsic, the common pathway of the clotting cascade, and then I'll show you all the different medications and how they work, like TPA, how does it work, like heparin, how does it work, things like that. Okay. Right now, what I want you to know is the blood sugar gets thicker. I mean, the blood sugar level gets higher and higher. It causes the thickness of the blood to increase. So the blood gets thicker. It doesn't flow as easily. Now we're likely to have these clots. Okay, what if I have a clot? So for instance, let's say if I'm in the heart. Okay, so if I'm in the heart, and remember we've got these big coronary arteries that supply blood to the heart. So let's say I damage this right coronary artery that supplies, for instance, the right side of the heart and the bottom of the heart. So if I damage this right coronary artery, we could have a heart attack there. Okay. What if I damage, for instance, this left coronary artery as it comes down and becomes the left anterior descending artery, or as it continues around and becomes the circumflex artery? If I damage any of those, so this one would be the circumflex, this one would be the left anterior descending. There's a whole separate video on EKGs and 12 leads, so I'm not going to get into that right now. What I want you to know is if we don't have blood flow to the heart, what's that going to cause? So that's actually going to cause, for instance, a heart attack. Okay? So if we don't have enough blood to the heart, that's going to cause a heart attack. What's our word for heart attack? So heart attack. What's our medical term? That's going to be a myocardial infarction. Okay. So one of the big complications of diabetes that's left untreated or that's not treated well is it can lead to heart attacks. Okay. Now, what if we have, let's say, remember how the blood comes, let's use the same picture of the heart again. As blood leaves this left ventricle and it goes through the aortic valve, and then back here, behind here, it's going to go through the aorta. Let me just draw out the aorta for a moment. So, as blood leaves this left ventricle, it goes through the aortic valve, then it gets into the aorta. And the aorta, remember how it arches like this? But off of the aorta, we have one branch here that's called the brachiocephalic trunk. Then we have another branch here that's called the left common carotid artery. Then we have this other branch that's called the left subclavian artery. What I want to draw your attention to is, for instance, let's say these arteries here. This is what's going to supply blood to the left side of the head and the right side of the head. Let's say if there's a clot and it travels up one of these arteries that supplies blood to the head, to the brain. If we have a blockage in an artery that's supplying blood to the brain, what's that called? That's called a stroke, right? That particular type of stroke is going to be an ischemic stroke. So it's going to cause a stroke. That particular one is called an ischemic stroke. What's the other type of stroke? The other type of stroke is a hemorrhagic stroke. Hemorrhagic. And that's where a blood vessel bursts and starts bleeding inside the cranial vault. Okay, two types of stroke, ischemic and hemorrhagic. Which one occurs most? Then about 72% of strokes are going to be ischemic strokes. By the way, since we're talking about it, let's talk about strokes really quickly. How do we recognize strokes? One of the things we want to do is what's called a FAST exam, okay? Okay, it's fast, and we want to think fast. So the F stands for facial droop. Okay. The A stands for arm drift. The S is for slurred speech. And the T is for the time of the onset of symptoms. Well, actually, let's correct that. Let's say that better. It's actually the last known normal time. Last known normal. Okay, let's break all this down. Facial droop. This is where you look at them and part of their face is like drooping down, okay? That's one thing that we're looking for. The other thing is arm drift. This is where we're going to have the patient extend both arms out, close their eyes, and we're looking for one arm to fall down. That's arm drift. Slurred speech. We're going to ask them to say something, maybe like, "You can't teach an old dog new tricks," or get them to repeat some phrase, and you're just trying to figure out, do the words come out and it sounds like normal? Or does it sound completely crazy? So that's slurred speech. And then the T for time is the last known normal time. Now, it's not necessarily the onset of symptoms, even though the onset of symptoms may be around the same time as the last known normal. But what we specifically care about is the last known normal time. So, for instance, let's say grandma goes to bed, and when somebody finds her the next morning, she's got all these crazy symptoms. She's got slurred speech, arm drift, facial droop. But somebody just found her this morning, but it didn't happen this morning. But the last time somebody saw her normal was last night when she went to bed. In that case, the last known normal time was last night. Why do we care? Because if you remember in the earlier video when I was talking about inflammation, I said the first players that come on the scene is the neutrophils. So let's draw this out for you. In a stroke or in inflammation period, what happens is, let's say at time 0, something happens. So let's just put a star here. Something happens. Well, about 4.5 hours later, this is where you have this cell type called neutrophils that shows up. Neutrophils come in and they bring an enzyme with them called NADPH oxidase. NADPH oxidase. And it causes all kind of free radical damage. Basically, it just comes in and wreaks havoc and just starts destroying stuff. The reason we care about the last known normal time in a stroke is if they're a candidate for drugs like TPA that are going to go in and dissolve the clot. We have to get that in there before these neutrophils show up, because once the neutrophils show up, it's going to cause too much damage and there's nothing we're going to be able to do. So this is why we say the quote unquote window period is less than 4.5 hours. Really, we say like less than 4 hours. The sooner the better. So the sooner we can get that patient to the hospital and either dissolve that clot or give the medications to dissolve it or surgery to remove it, the more likely they're going to be able to recover. Once they pass this time period, there may be too much damage and nothing we can do. And in this case, that patient could have permanent disability. So, so one of the key players that shows up is these neutrophils, shows up about 4.5 hours. And then after then, at about 24 hours, we have another person, another teammate that shows up, and that's going to be the macrophages. Okay. So here's what I want you to know. Neutrophils show up in about 4.5 hours. That's why we say the window period for a stroke is less than that. And then the next player on the team that shows up is the macrophages. Okay. So we just talked about stroke. So another major complication of diabetes is strokes. So let's go back to our little stick man here. And we're just going to put, for this brain, we're going to put strokes. Okay. What's our medical term for stroke? That's going to be a CVA, also known as a cerebrovascular accident. Okay. So those are some complications. Now, so let's go back over this. What we covered so far today is we said that diabetes mellitus is a disorder of the pancreas. It's a disorder because it primarily affects one organ, and that organ is the pancreas. The pancreas has two functions. It has an endocrine function and an exocrine function. The endocrine function produces hormones. Those hormones are made in this area called the islets of Langerhans. The islets of Langerhans produces three cell types. Those cell types are alpha cells, beta cells, delta cells. Alpha cells make glucagon that raises the blood sugar. Beta cells make insulin that lowers the blood sugar. Diabetes is a problem with insulin. And then delta cells make somatostatin. We talked about a drug that behaves like somatostatin. That drug is octreotide, which is used. One example that it's used for is esophageal varices. The exocrine function of the pancreas makes enzymes that aid in digestion. We said that diabetes comes in two flavors. There's type 1 and type 2. Type 1 diabetes is where you have insulin dependence, where your body is not necessarily making insulin, so you got to give them insulin. And the reason they're not making it is there's a problem with these beta cells. Okay. That's type 1. But in type 2 diabetes, that's where you have insulin resistance. Your body is making insulin. Like if we were to actually look for the levels of the C peptide, we would see that your body is making it. That C peptide is the protein that comes along with insulin. We would see you have C peptide in your body, so we know your body is making it. It's just not using it properly. Okay. We said that the normal blood sugar should be roughly between 80 and 110. The units are milligrams per deciliter. We're going to call it low or hypoglycemic once the blood sugar level drops below 60. And we're going to start calling it hyperglycemic once it goes to 200. Now, when it comes to hyperglycemic, there are different levels. We have hyperglycemia, then we have DKA or diabetic ketoacidosis, then we have hyperosmolar non-ketotic syndrome, HHNS or HHNKC or whatever, however your book calls it. Same thing. It's where the blood sugar gets super high. We talked about how do we diagnose diabetes. We look for a fasting blood sugar less than 126 milligrams per deciliter. But the real key is the hemoglobin A1C, and we want that to be less than 6.5, 6.5. Actually, we want it to be much less than that. So if we could get it to like less than 5.5, that's even better. When it comes to complications of diabetes, so the syndrome surrounding diabetes, remember it affects small vessels. I'm jumbling my words. It affects, and no, I'm not hypoglycemic right now. I've just been talking a lot. It affects small vessels and it affects larger vessels. In the small vessels, it causes this leakage called increased vascular permeability. And for instance, it can affect the eyes and cause diabetic retinopathy. It can affect the kidneys and cause diabetic nephropathy. It can affect the peripheral nerves and cause diabetic neuropathy. Okay. Or all that sugar can turn to sorbitol, can really affect those larger vessels. And now it can cause, for instance, clots. Let's say if we have a clot in a coronary artery in the heart, that can lead to a heart attack. But if we have a clot in the vessels that supply the brain, that can now lead to a stroke. We said there are two types of strokes. Strokes come in two different flavors. We have ischemic strokes, that's where you have a clot. Most strokes are ischemic. And then we have hemorrhagic strokes, that's where you have a bleed. How do we recognize a stroke? Well, we want to think fast. And so, if any of these things are positive, we are very suspicious that they are, in fact, having a stroke. We want to look for facial droop, arm drift, slurred speech, and the time. And specifically, the time is when were they last like their normal self. So I hope you learned something today. I hope this was interesting. What I showed you is how we could take a basic concept like diabetes mellitus, and from that one concept, if we know it well, we can go all over the place. If you notice today, we were talking about, so we were in the pancreas, then, then we went and we were all up in the brain, the eyes, the heart, the kidneys, the nerves. We were all in small vessels, large vessels. So think about how many systems we would be talking about. We were also getting into pharmacology. So we took one concept, and from that one concept, we were able to explain a lot of things. So what I want you to do is drop a comment in the comments below. Tell me what you learned. Tell me what else you'd like to learn. And I will see you very soon. Have a great day, everybody.